Hello, welcome
Hi.
to your physiology fiver.
Thank you.
Today we're going to be talking about hypoxia.
Okay.
What is hypoxia?
So hypoxia refers to a state where the cells are unable to undergo aerobic metabolism, either due to a failure of oxygen supply or a failure of oxygen utilization.
Okay, and what different types of hypoxia do you know? Can you give me examples?
So you can classify hypoxia depending on cause. And there are four kind of key classifications of it. So you can have hypoxemic hypoxia, you have anemic hypoxia, you have stagnant hypoxia, and you can have cytotoxic or histotoxic hypoxia. And we'll talk through each of those. So hypoxemic hypoxia is defined by a low arterial oxygen tension. And it can be due to any failure along the sort of the respiratory pathway of oxygenation. So it can be due to a reduced partial pressure of inspired oxygen. It can be due to alveolar basement membrane disease causing diffusion limitation, or it can be due to ventilation perfusion mismatching, or it can be due to excessive shunting of blood. Anemic hypoxia is where you have a reduced arterial oxygen content despite there being an arterial oxygen tension. And it can be caused by either a reduction in the amount of hemoglobin, so anemia, bleeding, hemorrhage, that sort of thing, or it can be due to a reduction in the binding capacity of hemoglobin for oxygen, as is the case in carbon monoxide poisoning.
Sure.
Stagnant hypoxia is where you have a normal arterial oxygen content and a normal arterial oxygen tension, but there is a failure of supply of that oxygen to the tissues. So this can be global or local. And so globalized stagnant hypoxia would be, for example, severe left ventricular failure. And localized might be areas of infarction. And finally, you can have histotoxic or cytotoxic hypoxia, which is where you have adequate oxygen content and delivery to the tissues, but the cells are unable to utilize that oxygen. This is, for example, the case in cyanide poisoning or in severe cases of sepsis.
Lovely. And what do you think we see most often in our clinical practice?
So the most common types of hypoxia we will see will be hypoxemic hypoxia,
Sure.
and fairly frequently anemic hypoxia.
Okay, now moving on, please could you draw the oxygen hemoglobin dissociation curve for me?
So the oxyhemoglobin dissociation curve is a curve that compares the arterial oxygen tension on the x-axis with the saturation of hemoglobin on the y-axis. So the arterial oxygen tension is usually expressed in kilopascals, and the saturation is expressed as a percentage.
Yep.
It has a characteristic sigmoid shape due to the cooperative binding nature of hemoglobin, i.e. the first oxygen molecule is the hardest to bind, and each successive oxygen molecule is easier to bind from that point onwards.
Sure. Could you mark on there the arterial, venous and P50 values for me, please?
So the typical arterial oxygen saturation will be expected to be approximately 100%, and that will usually correspond to a PaO2 of 13.3 kilopascals.
Okay.
Your typical venous content, oxygen saturation would be around about 75%, which will correspond to venous oxygen tension of 5.3 kilopascals. And the P50 value describes the arterial oxygen tension at which hemoglobin is 50% saturated. And normally that is 3.5 kilopascals, but it can be affected by a variety of factors.
Lovely. Now, what is oxygen content and how does it differ from oxygen tension?
So oxygen content, so oxygen is carried in blood in two forms. Oxygen is carried either bound to hemoglobin or dissolved in the blood.
Okay.
And so the oxygen content refers to the combination of these two things within blood.
Do you know any sort of equation for that?
So the oxygen flux equation is the one we use to calculate the oxygen content.
Yes.
So that determines that the arterial oxygen content is equal to, as we said, the bound fraction in addition to the bound fraction consists of your hemoglobin concentration, your saturation of that hemoglobin, so your saturation, and Höfner's constant. So Höfner's constant is 1.34, and this is the number of millilitres of oxygen that a saturated gram of hemoglobin of normal adult hemoglobin carries at 36 degrees.
Okay.
So that gives you your bound fraction, and then you add in your dissolved fraction. And your dissolved fraction is calculated by your oxygen tension, sorry, your oxygen tension, not very arterial. Your oxygen tension, and is not added, it is times by 0.02, because 2% of your oxygen content is determined by the dissolved fraction. I think I made a mistake here actually. I think this is not added, I think these are multiplied.
Okay. So in your blood, the majority, you're saying that the majority of oxygen is carried by the red blood cells, is that right?
So the majority, 98% of your oxygen carried bound to hemoglobin, 2% is dissolved.
Okay.
The tissues actually receive oxygen direct from the dissolved content, from the dissolved fraction, and then oxygen will diffuse away from the bound hemoglobin into the dissolved fraction down a concentration gradient to replace it.
You described the different types of hypoxia before very well. Hypoxemic, anemic, stagnant, and cytotoxic. Are you able to describe how arterial and venous oxygen tension alters in each of those types of hypoxia? We'll start with hypoxemic. So in the arterial system?
So hypoxemic hypoxia, as we've already said, is defined by a reduced arterial oxygen tension. So your arterial oxygen tension will be reduced in hypoxemic hypoxia.
Sure. And in the venous system?
So because your extraction ratio remains constant, your venous oxygen tension will also be lower.
That's right. And what about in anemic hypoxia?
So in anemic hypoxia, your arterial oxygen tension will remain the same, but because of the oxygen flux equation that we just talked through, your oxygen content will be reduced.
Your total amount that you can carry.
Exactly.
Okay. And what about in the venous side and the anemic hypoxia?
So you will still see a stable extraction ratio. So your venous oxygen content will be reduced, and likely your venous oxygen tension as well.
Sure. What about in stagnant hypoxia? Is the amount of oxygen carried by the blood any different in the arteriovenous system in that situation? In
stagnant hypoxia, your arterial system, oxygen content and tension will be the same as in normal physiology.
Okay.
The blood that gets delivered, because the blood isn't being delivered to tissues that are able to extract oxygen from it, your venous oxygen content will either be normal or slightly increased.
And in cytotoxic hypoxia, what do you see there?
So again, you've got normal arterial oxygen tension and content.
Yes.
But you'll have actually got an increase in your venous oxygen tension and content because the cells are not able to extract any oxygen from the blood.
Okay. Now, just for completeness, you drew a lovely graph earlier. Are you able to tell me which factors would move your curve to the right and to the left?
Okay, so factors that affect the P50 value of the oxyhemoglobin dissociation.
That's right.
So if the curve moves to the right, this decreases the affinity of hemoglobin for oxygen.
Okay.
So you have to have a higher PO2 to achieve the same level of saturation.
Right.
And you see a shift of the curve to the right in conditions of sort of increased metabolism. So high CO2, so hypercarbia, acidosis, hypothermia all shift your curve to the right. Increased levels of 2,3-DPG will also shift your curve to the right. That's what I can think of.
And what about moving to the left? What moves the curve to the left?
So to the left is the reverse. So lower CO2 content, alkalosis, hypothermia will shift your curve to the left, as will hemoglobin F, so fetal hemoglobin.
Okay, lovely. Well, thank you. That's the end of your Viva, with a few minutes to spare.
Thank you.
Maybe 10 minutes.
Cool. Thank you very much. Right, let me see if I can stop sharing. Good. Okay. Fine. So that's hopefully gives an idea of sort of the format of Viva station in combination with some hopefully useful information on hypoxia. Thank you.
But you knew all the answers.
Yeah.
In a real situation, they might sort of start really simply and then sort of lead you through stuff. And if you don't understand stuff, try and get stuff out of you. And some people just stop on the curve and they'll spend the whole Viva talking about that diagram. And really, that is sort of that's kind of more advanced, isn't it? I think
the comparative content in different types of hypoxia.
I think you're doing well in a Viva if you're getting onto that. I think most of the Viva would be looking at that. They'd expect you to know that diagram, but all the different, that's kind of advanced. So don't worry about having to know all that.
I missed the difference between tension and content. Online.
Basically, your blood carries oxygen but blood carries oxygen in different ways.
Yeah.
Red blood cells and dissolve.
Yeah.
And I think that's what it's talking about.
So tension is.
So tension is your dissolve, so it's your partial pressure.
Dissolve.
It's another word for partial pressure of oxygen, as far as I can establish. So it's your dissolve fraction.
Correct.
So tension and partial pressure are used interchangeably. So you'll have inspired oxygen tension is the same as inspired oxygen partial pressure, which is different from fraction of inspired.
But they affect each other.
Yeah.
Okay.
Thank you so much, Helen. So we'll try and get the screen to work for the next bit. If not, will you guys be able to? Oh, brilliant. Good. So the next bit, we're just going to do some practice sort of exam questions. I know, Catherine, you've done the MCQ, haven't you? But no one else has sat the MCQ, have you? Have you guys started preparing for it? Any of you? Sharon, you have as well. Good. Okay, so this will hopefully be some stuff that you've encountered and some forms you've encountered. So if you've got a smartphone, and obviously it's true for everyone at home as well, if you can scan that QR code, it should give you a poll to join. I'll see if I can get this to show. That's better, isn't it? Good.
So is this for the Friday? All of that?
Yeah. Is that what it
It's
is?
just
Okay. Have you guys managed to get onto it?
Yeah, it says there's no questions yet.
No, I haven't activated it yet, but so. Oh no. You've already done the MCQ anyway.
I'll shout.
You can just tell us all. You can just tell us all the answers, can't you? Good. Okay. So. Stupid.
Oh,
I might have done. Okay. So. What we'll have is we'll have questions, and then if you guys vote for the answers, read the questions in your own time. We'll get an idea of how many submitted their answers, and then we'll talk through them. Hold on. There you go. All right, my first time at this.
It's just one answer.
So there's multiple trials. So essentially, there will be each one will be either true. So tick the ones you.
Oh, sorry, I thought it was just.
Sorry, no, it's MTF, not SPS. My fault for not being clear.
This is from the blue book.
This one is. The next two, yeah, I've completely plagiarised this one. Full declaration of honesty. The next two are written by me.
What's the blue book?
The college's own exam preparation guide. It has about 60 practice questions in it. So you already know the answer, Frank. So you can talk to them. Well volunteered, my friend. Good. Okay. And we've got 4 people who've answered.
Well,
There's 4 of you. Good. Lovely. Okay. That'll do. So. a subject acutely exposed to inspired oxygen concentration of 10% at sea level will develop a respiratory alkalosis. Is true. Does anyone feel confident enough to tell me why and how?
Is it because they'll hyperventilate to try and compensate for that?
Yeah, why? What's the physiological mechanism? I had to write it down because it's complicated. Yeah, it'll be chemoreceptors, won't it? Because what do baroreceptors detect?
Pressure.
Pressure, exactly. So chemoreceptors detect chemical. Go on, yeah. Yeah. So where does your oxygen get? Where does your oxygen tension get detected? Carotids, and there's one more as well, I think. Aortic arch and carotid body chemoreceptors. So they will detect a low oxygen tension. No difference there, not content, but tension. And then they send afferent impulses up through the vagus and the glossopharyngeal nerves to the respiratory centre, and they increase your respiratory rate to blow off your CO2. Cool. So, subject acutely exposed to inspired oxygen concentration 10% at sea level will secrete a more acid urine?
No.
Why not?
Because you're becoming alkalotic, so you want to retain acid to maintain.
Exactly. So you will compensate for your respiratory alkalosis by creating a metabolic acidosis. Yeah. So you'll retain acid and mix alcohol. Absolutely perfect. We'll have increased pulmonary vasoconstriction. Yeah. So what reflex is this describing? Perfect. And what does hypoxic pulmonary vasoconstriction respond to?
Alveolar.
Exactly. That's the key thing. It's alveolar oxygen content, not arterial. Which confused me for the first few months of learning that. We'll have an increased cardiac output, and you'll know why. So as far as I could tell from my reading, I think this is because of the same reflex as increasing your respiratory rate. And your respiratory centre in your is next to your vasomotor centre, and there's some neural linkage between the two. So when you have stimulation of the respiratory centre, you also cross-stimulate the vasomotor centre, which increases your sympathetic outflow. So that's, as far as I could tell, the reasoning.
Yeah, it would make sense to increase them both rather than just one.
I imagine it's also to increase your oxygen flux, so your oxygen delivery to tissues.
Yeah.
And then the last one, respond immediately by increasing erythropoietin production. Not immediate, exactly. The key word there is immediate, and it is phrasing of this stuff with FRCA questions. Lovely, okay. Lovely. Happy to move on to the next one? Mm-hmm. So these are written by me, so apologies. I've managed not to show you the correct answer, which is good. Actually, Paul, go for it. Cool. Everyone happy? Sweet. Ish. Happy enough. Yeah. You couldn't cheat on this one, could you, Fergus? Yeah. Sweet. Okay. So with regards to hypoxia, diffusion limitation is a common cause?
I didn't say so.
No, the keyword's common, isn't it? And it specifically says in the textbook it's a rare cause.
It's because it's the traversing the capillary thing, isn't it?
Exactly, yeah. So that's a diffusion limitation. So this is talking about diffusion of oxygen across the alveolar capillary membrane. Is actually, oxygen is not really diffusion limited normally. It's perfusion limited, not diffusion limited. So you're more, it's more likely to be shown up by sort of exercise. So your oxygen is equilibrated with about a third of the way through the capillary, the alveolar capillary. That's sort of classic graph of oxygen equilibration on the journey. So you've got 2/3 of the perfusion time is spare. So it's very rare for it not to successfully diffuse and equilibrate across that membrane because it's so good at diffusing across it. So much more, what is a common cause of hypoxemic hypoxia? if it's not fusion. If we talked about 4 different type causes of hypoxemic hypoxia just now, so what were the other ones? So diffusion limitation. So there was of hypoxia, of which hypoxemic hypoxia is one, and then there are 4 different. So reduced, exactly, reduced inspired oxygen tension. So altitude, for example. You much more commonly will be things like ventilation perfusion mismatching. So you know you're perfusing a big area of lung that's full of pus because it's got pneumonia, so that blood is not going to get ventilated. So you've got ventilation perfusion mismatch, or shunting, which is similar. So those are your 2 most common things. With regards to hypoxia, anemia may be a cause.
Yeah.
Yeah, of anemic hypoxia. In histotoxic hypoxia, the central venous oxygen content is likely to be elevated.
Because it's not being utilised.
Exactly, yeah. So histotoxic or cytotoxic hypoxia is where your cells can't use the oxygen, so it just stays in the blood. The PaO2 is always reduced. The arterial oxygen tension is always reduced. No, anything with always in the title is usually a wrong idea. And in hypoxic hypoxia, the FiO2 is reduced. No.
Doesn't have to be.
I thought it would be.
Yeah, so hypoxic hypoxia is the term used to describe. So hypoxemic hypoxia is when your arterial oxygen tension is reduced. Hypoxic is when your inspired oxygen tension is reduced. But this is false because that says FiO2, not PiO2.
Oh.
So you can have a reduction in your inspired oxygen tension without a reduction in your inspired oxygen fraction. Because your inspired oxygen, so altitude being the classic example. So your inspired oxygen fraction at altitude is still 21%, but 21% of 50 kilopascals, not 100. So your inspired oxygen tension is halved.
Okay.
Not that I was trying to trap anyone. Cool. Oh, sorry. Happy? Anyone else? Got anything else to say about this?
Can I ask one thing?
Sure.
And why is it that the PaO2 on an ABG can be normal with carbon monoxide poisoning? Is it because the ABG measures tension, so the dissolved fraction?
So your arterial oxygen is what's measured with your PaO2 on an ABG, which is why advanced will, you presumably work with Gareth Moncaster?
Yeah.
He will look at the saturations, won't he?
Yeah.
He's not interested in the PaO2, he's only interested in the saturations.
That's fine.
Because 98% of your oxygenation is, 98% of your oxygen is carried bound, so the saturations is a far more significant determinant of your delivery along with your hemoglobin concentration. Now, in carbon monoxide poisoning in particular, how does carbon monoxide poisoning cause hypoxia?
So it comes with greater affinity oxygen. Well, yeah, the oxygen does.
Exactly.
So it just takes it, just binds up.
It binds hemoglobin and oxygen, so you can't bind the hemoglobin. So yeah, your PaO2 will remain exactly the same.
Yeah. Because
it's not affecting oxygen pressure, it's not causing shunt, it's not causing diffusion defects, it's not causing DQ mismatching, but it's stopping the binding of oxygen to hemoglobin, it'll reduce your oxygen delivery. But fine. Exactly. Good.
Thanks.
It's all right. Cool. Anyone else? Sorry. And the last one. Is that voting open? Oh, open voting won't help. All right, might start talking through these, I think, because we're just coming up to like 27 past. So regarding oxygen and the alveolus, dietary substrate influences alveolar oxygen partial pressure, true or false?
Yeah.
Okay, what? I think that's true. I wrote it. Go on.
Rings a bell, but I can't remember.
So do you know why am I?
So it's in the alveolar gas equation,
Exactly.
but I thought it was more related to CO2.
Which indirect influences?
Oh,
Exactly. So what's the alveolar gas equation?
PiO2.
Anyone know it well enough to write it out? Go on, let's do it together. I'm going to do it on here. I apologise to everyone at home if there is anyone at home. So go on. You said PaO2, so it's alveolar partial pressure.
PiO2.
Yeah. Okay.
I can't remember.
Okay. So I just wrote PiO2 down as well because I find that helpful. So what influences how much oxygen you have in your alveolus? So the things that influence it are the inspired partial pressure of oxygen. So it's your barometric, so FiO2 times your barometric pressure minus what? Exactly, yeah. So saturated break pressure water minus, because CO2 reduces your alveolar partial pressure of oxygen. So that's DaCO2 divided by R. What's R?
Respiratory quotient.
Good, and what's that?
That's derived from the dietary substrate.
Exactly. What is your respiratory quotient?
Normally 0.8.
Okay, so that's the normal value for a typical Western diet is 0.8. Fully carbohydrate-based diet will give you a respiratory quotient of 1. But what the respiratory quotient is the ratio of CO2 produced to oxygen consumed.
Oh, yeah.
So how much CO2 you're producing for how much oxygen molecule you're producing. So it's a ratio.
Yeah.
So that's your alveolar gas equation. So therefore, dietary substrate affects that, and therefore it affects.
Yeah.
Make sense?
Yeah.
So I think that's true, but I'm open to disagreements.
I'll let you on.
Cool. Alveolar partial pressure oxygen would be expected to be higher in West Zone 1 than West Zone 3. Anyone feel free to talk, happy to talk about the West Zones of the lung?
Ventilation and perfusion.
Yeah, okay.
So it divides the lungs in 3 zones.
Yeah.
The West Zone 1 being the apices, West Zone 2 being the middle zones, and West Zone 3 being the bases.
Okay.
And in each zone, the P to do with the partial pressure
So
in
what?
the arteries and
So it's pressure, not partial pressure. So it's
pressure in the arteries and the veins. I don't know if I can
Yeah.
say it properly.
Go on.
So zone 1, P.
You took me on the right track.
Yeah.
Yeah. So P capital. I think I remember this right. I don't know.
Go for it. All right. Brilliant.
So 1, P A is greater than P A, which is greater than P B.
Yeah, perfect. Good.
That doesn't ever really exist.
Yeah.
Apart from in P for something.
If you have really high PEEP or gas trapping and asthma, you can give it right zone 1 physiologically, but in normal physiology, you don't see it.
Zone 2.
So the 3 variables we're talking about here, just quickly, Duncan, you're doing perfectly, you're doing great, you're going to know that I know already. So the 3 right here are PA with a big A is alveolar pressure, PA with a small a is arterial pressure in terms of your pulmonary artery, and PV is your pulmonary venous pressure. Now, your pulmonary arterial pressure must always be higher than your pulmonary venous pressure, right? So P small a is always greater than P small v, isn't it? So therefore, the only thing that moves is P big A. And that's really easy. It's like noughts and crosses. It goes back, left, middle, right. Zone 1, 2, 3. So zone 1 is where your alveolar pressure is greater than both your arterial and venous pressure. So i.e., there's so much pressure in your alveolus it completely compresses the vessels that supply your alveolus. So your alveolus then becomes what? There's a special word for what it becomes. respiratory dead space. It is ventilated, but it is not perfused. So that's dead space, that increases your dead space. That's what gas trapping is. Zone 2 is what you want physiologically, nice, healthy, happy lungs. Arterial pressure, so you've got some supply of blood into the alveolus, and the alveolar pressure, and then your venous pressure. And then the other two is arterial and venous pressure are both greater than your alveolar pressure. So your alveolus is collapsed, and so that's called shunting. All right, and so you do see that in the bases. That's sort of atelectasis is when you see that. Cool, so that's your 3 West zones. So going back to the question, alveolar partial pressure of oxygen will be higher in West Zone 1 than West Zone 3, and why? What, if you don't perfuse your alveolus, what's not going to get into your alveolus? What does your blood returning from the rest of the body take to your lungs for excretion? CO2. The CO2 will dilute the gas in your alveolus, so you won't have oxygen diluted by CO2. So you'll have the alveolar gas equation, but without the CO2 bit on the end because you're not using it. Make sense? So sorry, I've tried to write a question that brought in different bits of physiology that we could talk through, so we did a bit of respiratory physiology in 10 minutes. Sorry, it's quite a lot. Alveolar partial pressure of oxygen is equal to arterial partial pressure of oxygen, true or false? False, why? Anyone want to volunteer an answer?
No, I said it was true.
Okay, why do you say it's true?
Because I thought that it was assumed that
Surrogate.
in the shunt equations and things, I thought that because the diffusion was complete, you could assume that they were the same.
So
I don't know if that's just for the sake of that equation.
So what do your oxygen diffuses down a concentration gradient is the first key point here.
Oh, of course.
Into your capillary blood.
Yeah.
And then your capillary blood combines and meets other blood in your pulmonary venous system before going through the left side of the heart and out into your arterial system. So something else gets added to blood.
The stuff from like the Bayesian vein.
Precisely, a physiological shunt. So there is always some shunted blood. So there are 2 sources of physiologically shunted blood, Bayesian veins and what else? Bronchial circulation. So your lungs nutrient perfusion rather than your lungs like function. So they both get added in the left side of the heart after the return of blood from the capillaries. Okay, so your arterial oxygen PO2 will always be less than your capillary oxygen PO2. Okay. No respiratory gas exchange occurs in the tracheobronchial tree, true or false?
False.
False. Why?
It's kind of, you have to say what tracheobronchial means. Does it mean, well, I took it to mean bronchioles where gas exchange does occur.
Which bronchioles does gas exchange occur?
Don't know.
Respiratory bronchioles.
Yeah.
They've got respiratory in the name, so they're respiratory bronchioles. So yeah, absolutely. It's the main reason this is false is because it's got the word no in it, which is another way of saying never. Because you could rewrite that statement, couldn't you? Just say respiratory gas exchange never occurs in the tracheobronchial tree, and then it's obviously false.
Yeah.
So yeah, no, so your conducting. This is about your respiratory versus your conducting zone. So divisions of your tracheobronchial tree. From I think it's 16th division onwards is where you start to get into the respiratory zone, and that is your respiratory bronchioles, your alveolar ducts, and your alveolar sacs. And that's where you start to get gas exchange. So 10% occurs in the respiratory bronchioles and in the alveolar sacs, and then 90% occurs in your alveolar ducts, and then 90% occurs in your alveolar sacs. So that's what that's talking about. And then last one, sorry, I've been a bit of a slog. Rate of diffusion across the alveolar capillary membrane is dependent on molecular weight. True or false?
I said false.
You said false.
I said false.
Yeah.
Okay, so what are the factors that affect diffusion across a membrane? 6. Yep. I think there are 5 personally.
It's the concentration gradient.
Yeah, concentration gradient is probably the main one. So it's not the main factor that affects it, but concentration gradient is the main factor that affects it, I think.
Diffusion constant.
So solubility, yeah.
Yeah. Thickness, have we had thickness?
I think you said thickness,
Surface area?
surface area, and the last one I think is molecular weight. So I think your rate of diffusion is inversely proportional to the molecular weight of the substance. And I think that is, I can't remember whose law that is. So I think thick is one of them, not all 5, which is what I initially thought it was, but I'm not sure. Yeah, cool. Fine, that's all I've got for you guys.
Thank you.
That's all right.
That's really good.
It's all right. So what we're going to try and do is do a different theme of topic each week. So we'll do like a week on physiology, week on pharmacology, week on physics, and then loop through again and try and cover different bits. And hopefully through this, you can see I've tried to cover a chunk of respiratory physiology in one go rather than just one area. Going forward, obviously I volunteered for today for being interviewed, and I'm happy to do the next one or two, but actually going forward is quite good for people, especially people who have done the MCQ already, to start doing it, because it's quite a good opportunity. You get a chance to prepare, you know what's coming up, and it's just a chance to look over the topic in your own head, and there's nothing quite like being put on the spot in front of people to make you learn a topic, believe me. So if you guys are happy to volunteer for that, people who are in primary land at the moment, then I'd be really enthusiastic to have you guys out. And then similarly, if anyone wants to take over the role of examiner, if we struggle for a consultant, I'd always help.
Happy to.
Be good to have someone. Yeah. It'd always be good to have someone to read out the questions. Cool. Thanks.
Thank